everyone. It's a great honor to be presenting to you today about how we're thinking about precision and personalization when it comes to our cancer members' journey, all the way back from South Africa. So I think first, just to start with a background and introduce you to what the South African healthcare system looks like. If you look at the graph on the left, we've got two big sectors. So the public sector, that we serve around 86% of the country's population within the public sector. These are through public fundings, funded by taxes, and mainly it's government-owned hospitals and clinics. On the other hand, we have the private sector. So the private sector only covers 14% of the country's population. These are private funding organizations that are funded through contributions. So member pay a contribution to belong to one of these medical insurance policies, and we mainly have privately owned hospitals and practices. However, if you look at the graph on the right, what we see is given this distribution of the beneficiaries and also almost a very similar distribution in terms of hospital bed capacity, there's an imbalance of resources that are being spent between the public and the private sector. So almost half of the expenditure, healthcare expenditure, happens in the private sector and another half in the public sector. So some of the key challenges we're facing in the public sector at the moment, and I think these are not unique to the South African context, is that we see that medical inflation is rising much faster than CPI. And why this is happening is because the young and healthy that are meant to cross-subsidize the elderly is not buying into private healthcare funds because of affordability issues. So we see that utilization is the primary driver for this medical inflation that we see. And as a result, that leads to our second point, where we see a rising burden of lifestyle diseases. So given that the population that we look after is aging on a yearly basis, we have more chronic conditions and more cancer in that population that are coming at a significant cost. We also see that we have a variable quality of care and value for our patients. So nowhere in the system are there standard reports in terms of the quality of care that our members experience. When we do our own reporting, we see variability across readmission rates, mortality rates across each of the hospital groups. So really no consistent reporting also happening and visibility around the quality of care that our members experience. We have a very fragmented system. The patient could literally go to any doctor, any provider that they choose within this environment. There are no entry points, so nowhere do the patient have to enter through a primary care provider. They can literally go wherever they want. And this leads to a lot of overutilization, and a lot of this is due to us not having a single EHR that consolidates all of this information. And also another phenomenon, we see a lot of fraud, waste, and abuse in the system. So where does Discovery fit into this whole ecosystem? So Discovery is our largest health care administrator in South Africa in the private sector. We administer 18 what we call medical schemes, so health policies or health funding policies. And Discovery Health Medical Scheme is the largest open administrator in this market. We cover around 3.5 million of that total 9 million population in the private sector. So our purpose at Discovery is we want to make people healthier and enhance and protect their lives. We have a very broad, ambitious ambition, and that is to be the best insurance organization in the world. We want to impact 100 million lives globally and be a powerful force for social good. And all of this is done through our shared value model. So all of our businesses are underpinned by Vitality, which is an incentive-based program that members buy into. So members can opt in to belong to the Vitality program, and here what they do is they incentivize members to show them healthy behaviors. So for exercising, choosing healthier foods, etc., you get an incentive. And through that incentive, what happens is that the insurer finds lower claims, fewer illnesses that the insurer have to pay out, and all of that making the society a more healthier society. So all benefiting in the end. At Discovery, we have an extremely rich data set that covers many broad sort of aspects, both from a structured data perspective as well as an unstructured data perspective. So we have lots of information about our members, lots of demographic information, From a clinical perspective or a claims perspective, we have well-coded data that spans many years of information. We have audited information. We audit all of our mortalities, our underlying cause of death. So we have a very rich data set that enables us to do extremely rich data analysis. So if we look at what we've seen playing out in our environment, so if we look at the cancer screening trends for Discovery Health Medical Scheme, unfortunately, what we've seen is that there was a significant drop in a lot of these screening rates evident through the COVID pandemic. So in the years 2020, 2021, a huge drop across many of these cancer screening trends that we've seen. Fortunately, by 2024, we've recovered for most of these screening trends to pre-COVID-19 levels. So a great impact will be seen, I guess, in future years in terms of when members are being picked up in their cancer journey. What, however, is a very fascinating thing to see is that for our Discovery Vitality members, all of the screening rates across many of these screening trends are higher for the Vitality group compared to the non-Vitality group. So evident that this incentive program does change the behavior of our members, and we see a better behavior in that Vitality group compared to the non-Vitality group. So we were in a very fortunate position to be contributing to and publishing a paper in the South African Medical Journal when we started looking at our mortality trends or our death rates for our members. And the reason why we were sort of first to market in this space is that overall in the South African context, coding the underlying cause of death is significantly delayed. So at the time of publishing this paper, national statistics were only available up until 2018. So it's going to still be a long while before we have access to national underlying cause of death and mortality data. So we were first to market from a discovery perspective to be reporting on what we've seen in terms of mortality trends over time. So I think three main things that came out of this analysis was that first, if you look at that graph, we saw that the scheme had experienced the highest level of mortality in the history of funding for these members during the COVID pandemic. So that huge bump you see play out in 2020 and 2021. Secondly, if you look at the graphs on the right, we've seen a change in the distribution of the underlying causes of death. So fascinating to see in 2012, we still had quite a significant proportion of HIV deaths in the Discovery Health Medical Scheme population. And you can see how that has become a lot lower in 2022, 10 years later. You see COVID deaths coming up quite significantly in 2020 and 2021. So change in the distribution of the underlying cause of death. And also finally, we saw for the first time in 2020, that cancer had overtaken cardiovascular disease to become the highest underlying cause of death for our population. We then looked at our 5-year relative cancer survival rates and how this compares to some other published information. So what we did is we looked at the four main cancer types, so breast cancer, prostate, colon, and lung. And what you see within that DH bar, that light green bar on the left, is a variation within the discovery population. And that variation comes from the different benefit options that the members buy into. So in the medical scheme, there are different plan options, and these plan options cover different, a range of different benefits for the member. So member can buy into at a lower premium for a restricted set of benefits, i.e. only have access to hospital care, and then you pay a lower premium, versus all the way through to our more comprehensive offers that covers both your in-hospital experience, a higher cover for oncology-related expenditure, and then covers most of your out-of-hospital expenditure as well. And what we saw is that across most of the cancers, our higher-end plans, or more comprehensive plans, are in line with international experience. So the data that we're seeing very much aligned with some of the international experiences. So then if we turn to our oncology landscape, so what do we see play out in our data? So firstly, we have seen over time that there's this growing incidence of cancer amongst our younger population. So if you look at that graph on the left, all the cancers in the red triangle are cancers where the growth rate in the population younger than 50 had been higher than the growth rate in the population over 50 in the last 10 years. So we know at an absolute prevalence rate, these cancer prevalences for the younger population are still at a lower level compared to our elderly, but the growth rate is of concern. Secondly, we've seen an accelerated introduction of new therapies come into the market over the last 10 years. So for our population, we've seen 51 new drugs enter the market. We've covered only for a small proportion of patients these new drugs, and you can see the significant amount of money that we've spent on only a subset of these new therapies. These new therapies are great because what we see is people are living longer. So that was evident we did a piece of analysis of looking at our breast cancer population, so adjusting for everything else, keeping everything else consistent, same age, same demographic markers, same genetic markers, etc., and just varying the time of diagnosis. So people that were diagnosed in 2008 to 2011, relative to those diagnosed in later years, you do see that survival is higher, so a lower chance of mortality as survival over time does increase. Another phenomenon that we see play out is this rising end-of-life care costs. So in 2023, we had just over 3,500 members that died because of cancer, and that represents a very, very small proportion of the total members that we look after. However, if you look at the spend that we had spent from a scheme's perspective on these members in the last 6 months of death, it makes up quite a significant amount of money. So 11% of the total money that we paid on oncology-related care was for people in the last 6 months prior to death. We also know that there's lots of clinical trials, and these things come out on a daily basis. And often these are very broad and done in a very controlled environment. And they typically also exclude the very elderly, people with multiple chronic conditions, very controlled, and they're not often reflective of real-world dynamics. So what we have access to is a huge amount of data in terms of real-world experiences and real-world dynamics. We've heard yesterday from the breast cancer advocate also this model of starting to think about understanding the patient holistically, not only focus on the survival outcomes, but also start thinking about at what cost does it come, at what quality of care does it come, what is the effect of these things on the patient. So really starting to think about how do we shift that paradigm from only focusing on the survival benefits and start thinking about a more holistic picture for each of these members. So if you look at the current process in our market and on what happens, is that the doctor would have a patient in front of them. That patient has certain characteristics attached to them. The doctor obviously has access to a bunch of clinical trials that they keep up to date with. In the South African context, we have two big provider groups. So the one called SCON, the South African Oncology Consortium, and another one, SCON. So these are two big provider groups. And I think we've heard yesterday also that this phenomenon of having also different guidelines and different protocols. And exactly the same is happening in our environment, where if the doctor belonged to SCON or doctor belong to the SCON network, they're very different guidelines in terms of the recommendation of treatments for these patients. So what we've tried to illustrate in the graph, and what you can see, like with those sort of like gray lines going at the back, a very similar patient, dependent on which clinical trial is referenced and which provider group they belong to, could end up on very different treatments in the environment. And I think currently the main focus, as we said, is on survival and what benefits the patient could get from the prescribed treatments. So what I want to introduce you today is a tool that we've developed called TreatMe. So this tool, given that we're sitting on this wealth of data and well-coded data over the last couple of years, what we can add to the process is both on the left and on the right-hand side of this current process. So on the left, what we have access to is real-world experiences, real-world data in terms of survival, in terms of costs, in terms of experiences. And all of this we've done through some advanced AI and machine learning models to start bringing this information into the process. We also on the right are adding to not only looking at survival and the benefits that these patients would get from these treatments, but also start exposing the cost of these treatments, the cost of the potential side effects that these patients would experience, and what is the quality of life that these patients would experience. And all of these we have underpinned by what we call SARA. So SARA is our locally developed, called a ChatGPT, that the provider could interface with. So it's a single front-end interface that you could put in some information, you could ask it a question, and it brings back all of the information for you. So this is what the current TreatMe front-end interface looks like. So the provider would go into the interface, they could select certain things. This is just a demo. We're working on bringing in other fields and more I guess, treatment options and things into this. So for the moment, the doctor is able to select, this is the cancer I'm looking at, this is the benefit limit, or the plan that the member is on, certain demographics around the patient, whether it's a metastatic cancer patient or not, whether the patient had had prior surgery, radiotherapy, and then they could select the lines of treatments that they want to put the patient on. So in this example, the patient was on carboplatinum, paclitaxel as a first line of chemotherapy treatment, and that had failed, and I want to put the patient on Keytruda. And you basically just say to this engine, give me as much information that there is available about this member. And what it does is it does three things. So literally in a click of a button, this engine does three sort of summaries for the provider. So firstly, it goes and collects all of this real-world data, and it summarizes it for you in a beautiful graph like this. So taking that survival information to say that based on our data, for other patients with these similar characteristics, what we've seen is that there's a 20% 5-year survival probability for these patients. The quality of life by putting the patient on the first-line treatment has a value. The quality of life by putting them on the second-line treatment has a value. And then what you're able to see is for each of these drugs that has been used in the environment, what are the additional months that we're going to add to the patient's life based on the real-world experience? What is the cost of that drug? What are the cost of the potential side effects that we're going to be experienced by putting the patients on these things? And then this out-of-pocket expenditure, given that we have the different benefit options, we don't cover everything in full for each of these different benefit options. So patients are oftentimes left with a co-payment that they have to pay out of their pocket for these treatment options. So it starts giving some information around to start thinking about this patient a little bit more holistically. And then it gives you information around the second line of treatment. So if you had to put that exact same patient on the second line of treatment, what are the additional life months, the cost of the drug? And then here you can see, for example, Keytruda isn't funded in full for patients on this benefit option. So at that point of the consult, you already have information around what the patient could potentially be needing to spend out of their own expenses. Secondly, what it does is it references and it goes to all of the different sites, and it fetches all of the clinical trial information for these relevant chemotherapy drugs. So it lists all the clinical trials, it gives you a quick summary about these trials, and you've got the ability from here to click out and then open up all of these published information. So really just collecting all of this information, summarizing it in a quick front-end interface for the doctor to engage with. And then thirdly, and I think this is where we're spending a lot of time trying to understand these different protocols and these different guidelines. So from each of these two different provider groups, from ICON and SOC, where are the overlaps on their guidelines? Where are there discrepancies on their guidelines? And starting to expose some of those things into the environment. And we're also doing a lot of work internally to understand where these guidelines differ, to really just start, trying to create a single integrated guideline across the country with evidence-based medicine. So really we think TreatMe, this tool, is really going to help in the environment to improve resource allocation. There'll be a time efficiency internally as well as externally for us to review these requested treatment guidelines. we're hoping that this will enhance the quality of care of our patients, will increase our member satisfaction, improve the patient well-being overall, and help the scheme with the long-term cost sustainability. Thank you.
I have two questions. Has the system been validated? And what is the economic breakdown of the patients that actually can use this system?
Yeah. So at the moment, validated, we're working with that process. So we've got a lot of people internally that are looking to just ensure that we've listed the appropriate trials, that the clinical guidelines are coming through effectively. In terms of validation of the discovery real-world data, there we don't need any, proper validation because it's just experience. We just report back to say, for other patients with these characteristics, this is what happened in the past. We haven't yet given this externally to any provider to use, and we think it's going to still be a long while before we can release it to the external environment. So we're doing a few pilots internally with our own case managers, with our own internal staff to start using the tool when we get these treatment requests, to start bringing this into the process as another data point, another thing to start discussing, or at least just have discussions with doctors in a different way. I think one of the comments we often get is that providers, obviously, they have the patient in front of them. They've got the family pressurizing them for the best treatment options for the patient. And they oftentimes send us these requests in the hope that we, as the administrator, would decline it because they know that there's no benefit for the patient, but they're still trying. And then we just approve because it's part of the benefit options. So we're hoping that this will at least just give a bit of a different discussion point. Ultimately, the decision to put patients on funding remains with the provider, and we're not going to make any recommendations in terms of changing those things. But at least we can start enabling different discussions with the providers and start giving them some different data points to consider in making their decisions for putting patients on certain treatments. We're also working quite closely with a professor from one of the local universities to try and validate the discovery model experiences. So we're doing that process. And then I think the next validation process we'd like to do is to sit with the ICON and SOC boards to take them through the tool, to expose it to them and start getting their input and feedback in terms of the validation. So we're still quite far away from giving it in the hands of the members. So that process we haven't kicked off yet. We want to do the internal pilot process first, get it in the hands of the providers, and then hopefully eventually get it to the members. So we're still quite far from that member front-end facing process.
One issue that I brought up yesterday when the panel started, there's a big difference in guidelines because you have the two providers of guidelines that may or may not be harmonized.
Yep.
Then you have institutional guidelines,
Yep.
divisional guidelines, personal guidelines,
Yep.
and they don't agree. And then you have clinical trials where they're not even trying to follow guidelines. And so how do you bring all of that information together for the providers?
Yeah, so that's exactly what we're trying to do, is firstly just bring the two local SOC and ICON guidelines together and start exposing where there are differences in the guidelines. So we've seen, in the lung cancer space, for example, one of the earliest drugs that came out is still in one of the providers' guidelines. However, the other one have taken it out. And we want to start exposing these things and at least try to have a national guideline that are consistent across those two. And then we'll have to start with the next process. So it's going to be an iterative process. I wish we had the answer to that.
Just to give you an example, one of the clinical sites we work with, the chief of a division had moved from another hospital. he uses a certain drug in treatment. It's a pediatric condition. He uses a certain drug as the first line of treatment. The place where he left, they're not allowed to use the drug at all. And that's the kind of conflict you run into in
Yeah.
real-world practice that needs to be understood
Exactly.
and brought forward.
Exactly.
It's confusing to the patient, for sure.
Exactly.
So, but thank
Yeah,
you.
So we're hoping through this process just to create some visibility around that, which also doesn't exist in the environment.
Well, yes. Well, thank you very much for your talk. And it's more or less the same that putting the two talks together, trying to come to reality, where I'm involved and we're trying to build in Chile the two kind of platform, one for people living with HIV and people living with cancer. One have more a deadline than the other one. And coming to real life, because it's the problem that we're facing is we have exactly the same. Yes, I'm trying because working with data, but in real life we have so many differences. Socially speaking, like the talk before, kind of know the patients are coming, or we are not be able to, although we are trying to do the best, yeah, but we are kind of, our hands are completely tied. I'm coming from a meeting before here, and basically like 15 patients left. We were trying to say today, what can we do? We are just doctors, we are just scientists, and so in that experience that you work with the people, what did you do when you just patients say, look, I have no money to travel, I don't have money to pay, the bus to come, 15 minutes. I'm working, I can take another day off to go and pick up the pills. So, so something so simple, yeah? So what is in your case, or do you build something more socially to accompany the patients, to be able to go, to be able to, thinking about Africa, that you are in this kind of huge problems probably to face with. So how do you, manage to have the people arriving?
Yeah. I think it's slightly different in the private sector. I mean, like the access isn't a problem. So I think the public sector do face a lot of more of those social, economic issues. The private sector, the access isn't an issue. But yeah, I mean, like socially, there's so much more we can do in terms of getting the treatments to the right people and things. So I don't think we have the answer. We're working we're working through the data and trying to find meaningful ways to engage with the doctors, with the patients. But yeah, I don't think we have
Patient adherence is a global problem.
Yeah.
So any kind of guideline or recommendation, it's not something local and very
Yeah.
complex.
Yes,
Very.
we are
Yeah.
facing this every day. And we are working with private sector.
Yeah.
What can we do? Because at the end of the day, patients left.
Yeah.
Well, then, and
Yeah,
to
same
take
issue.
off from Gail's presentation, we work with we've done work in the past with a lot of, in the U.S., what we would call immigrant populations, where we have multiple generations. And there's a lot of effort to look at social determinants of health. But what we've had to integrate into that is the idea of cultural determinants of health and trust determinants. Because what happens with social determinants is you're sort of looking from the outside in and saying, this is what you should be doing, and you're not acknowledging that culturally it may not be acceptable. And the example I always give is someone who uses tobacco in a religious ritual is not going to think they smoke. But of course they smoke and they're exposed to smoke. And you need to understand that because it's going to impact everything else.
Yeah.
So these are very complex issues. That's why we have meetings like this to discuss them. So
Thank you.
let's thank Lizette again.